But then I would love to discuss with Professor Quinn-Liven, I know she's still there, about like how then could you make optimal use of telemedicine in models where clinicians look after adult Duchenne patients. What is your perspective?
Yeah, I think, I think it's really useful, but I think you need a structured approach, rather like Esther's presentation. So, for example, for our outcome measures for the North Star, because we do standardized UK measures, we adapted all of our measures so that they could be done remotely, but in the same way across the whole country. So I think it's similar to the work that you're doing. And I think telemedicine is the way forward, but I think it's not the only way forward, because we still have to do heart scans. We still have to do check the ventilator, make sure it's working okay, make sure the pressures are okay. So I think you probably need a sort of hybrid approach with some visits to the center and some visits remotely. That would be my guess. But as I say, the remote visits, it's better if they could be standardized in some way.
And I saw also it's gone now, but I think home visit also scored quite high. And I think Ulla Werlov, are you there? Ulla is from Denmark and she is there since a long time. So they have a lot of experience in more, seeing the patient outside the hospital. But I don't know, Ulla, are you there?
No, unfortunately, she's not with us right now.
Okay, that's a pity because I saw she was there and SPI could not attend. Okay, so and then maybe I would love to have people in the chat suggest what their questions are about these or telemedicine or visits at home or the London system or the enhance the role of the general practitioner in their country. So please comment so we could go through this together. Meanwhile, I asked Doris Long from the US to respond to the outcome of this questionnaire or this poll.
Oh, thank you. Hi, everyone. So interestingly, we'd actually started doing a lot of telemedicine during the pandemic. There was very, very little, and suddenly there was a whole lot of it. And so interestingly, during the pandemic, it was considered being used on an emergency basis, and so all of the licensing requirements were basically lifted. And what had previously kept telemedicine from being more common is that in order to practice medicine, you need a medical license, and a medical license is like many things, they're given by state, right? And so if you are licensed in California, you cannot practice medicine in other states, and you can be licensed in many states, but it's very, very costly. And so telemedicine, the way that it is, billed and the way that it is structured, you are practicing medicine in the state where the patient is, right? And so if I'm sitting here in Maryland, licensed in Maryland, my patient is in Arizona and I'm not licensed in Arizona, I cannot be reimbursed for telemedicine visits that I am doing. And so there has been a lot of, and I think that, during the pandemic, people started to see the value of being able to do this, because it would provide access to care that people would otherwise not have, and access to expert muscular dystrophy care that they may not have locally. But we have not yet arrived at this point where there can be sort of, universal licensing, even though I think that there are a lot of physicians who do think that there would be value, like tremendous value in being able to kind of see telemedicine patients in other states.
Yeah, Professor Dubrovsky, yes, we see your hand. Go ahead, please.
No, we had a very good experience with telemedicine, and I think it comes to solve many problems, but it has to be used very wisely. Okay, it's not just telemedicine and that solves everything. You need to examine the patient many times, and you need to be there examining the patient. And the patients have to understand that It's not just a matter of talking sometimes, which is very useful many times, but many times you also need to examine the patient. And this is something that you can sort of regulate probably through the visits, through the telemedicine visits, but it's not, that does not replace examination. So it's a very powerful tool, but I think it has to be used wisely and based on clinical knowledge. Okay, this is.
I see Professor Quinlivan. Thank you, Professor Dubrovsky.
Yeah, I totally agree with Professor Dubrovsky. I think that's right. We moved to telemedicine during the COVID pandemic. And I have to say we had our fingers burnt a few times by, missing things, that, as you say, you have to examine the patient. We tried posting out oximeters to people so you could do home oximetry, but you don't get as much detail. We're interested in the carbon dioxide levels as well as the oxygen levels. So I totally agree. I think just doing telemedicine on its own is you'd have to, wouldn't benefit patients. And but I think there are some real advantages to doing a hybrid kind of model.
Yeah, so then maybe if there's still anyone who wants to comment on this or say something, then I feel that the conclusion could be that together with the people who have experience and the patient, we should come up with a model which would work for Duchenne, adult Duchenne, in terms of the progression of the disease, in terms of what are the risks, in terms of how it could be part of care. So there would be some suggestion if a certain group or country want to do it, and we can learn from each other. So here somebody asked, like, what about combining medicines with wearables to collect real world data and enhance monitoring? I think wearables is definitely something which is, you can also do the ECG. By the way, you can also, with the transcutaneous, you can measure the CO2 as well. So, and you can, like, we email that to the clinic. You can do that. There are a lot of things you can do, but I think it also should be feasible. And as Sally is saying here, the hybrid model would be best. Sally Hofmeister, she's in the field for a long time as well, but I think that is, might that be if I say that might be the conclusion of this discussion, am I correct? Or are people raising their hand and say, no, that's not I don't see hands. Do you see, Suzanne? People who raise their hands? No, I don't see this. So I would suggest with this to thank everybody who presented here, who attended here. It has, at least in my opinion, been a fantastic, inspiring 2 days to see how we can bring adult care to the next level for everybody around the globe, not only the people who are in the centers who are already doing well, but also in the places where a lot of improvement is needed and maybe feasible. And we could think of a next, maybe a workshop of people who are interested to see if we could come up with a workshop paper about the place of telemedicine in adult Duchenne care. So with that, I thank everybody, the speakers, the people, and also the people Nicoletta interviewed, because I know these young men are super relevant to all we do. So thank you. Sorry, 5 minutes over time, but I wish you all a good evening, and I hope to see you soon on another meeting. Thank you. Bye-bye.